Thank you, Miriam, and thank you, everyone. I'll just get started, but I do want to acknowledge the team involved in this project. Their names are all over there, and I'll be acknowledging them later in the slides. So thank you to everyone that contributed to this project, both at Calvary and at the University of Technology, Sydney, and Stanford University. So we know that breathlessness is a distressing and debilitating symptom in palliative care patients that interferes with functional capacity and quality of life. We know the risk of mortality is increased by 80% with the presence of breathlessness compared with advanced cancer patients who do not have this symptom. And we also know that chronic breathlessness is systematically under-recognised and under-treated in palliative care. Assessment of breathing-related distress is essential to address psychosocial issues and cognitive processes as well that drive breathlessness. And this is particularly important in our setting. So based on our 2020 palliative care outcomes collaboration data, we found that 1/5 of patients admitted to home community palliative care services with moderate to severe breathing-related distress did not have their breathlessness reassessed or documented within 7 days. And therefore, we found that the service was not providing adequate responsive care for patients with breathing-related distress. So our quality improvement project therefore aimed to improve the timeliness of breathlessness assessment in our service in New South Wales within one local health district. And this aligned with both the goals of the service and with the palliative care outcomes collaboration to reduce both the burden and impact of refractory breathlessness and to achieve the national benchmark. So our SMART goal aimed between the 1st of May and the 31st of September 2021 to increase the proportion of patients with moderate to severe breathing-related distress on admission to community palliative care services who had a repeat assessment within 7 days from 34% to 90%. And breathing-related distress was a moderate breathing-related distress was defined as a Peacock Symptom Assessment Scale score for breathing problems of 4 or more. So again, just acknowledging our team, our quality improvement project was set within one Australian specialist palliative care service. It involved 24 staff members and 181 episodes of care. It was done as an international collaborative project involving Stanford University and the Australian Sphere Palliative Care Clinical Academic Group. So on the screen there are all our members, except of course for Jake Mickelson and Dr. Michelle de Natal, who were the Stanford collaborators. So our project involved a process of monthly 1 to 2 hour remote mentorship sessions via Zoom teleconferencing, didactic instruction and project-based learning and quality improvement. The project team met on a fortnight to monthly basis as needed to undertake project activities and to ensure the timely progression of the project. We firstly undertook a root cause analysis using a cause and effect diagram where we brainstormed ideas within our multidisciplinary team and assigned weights to those which we felt was modifiable within the scope of our project. So on the left, you see the identified problems and circled are the ones we felt we could best impact. And these then informed the 4 key drivers that were identified. And these were on the right of the screen. Firstly, 1, consistency of practice in scoring. So we wanted to make sure that clinicians were scoring distress and not the severity of breathlessness, and then how we act on that. Generating a preventative mindset that's proactive and not reactive. So making sure that we assess scores before a crisis situation arises and not on Friday afternoon. We wanted to promote timely allied health breathlessness referral where that was possible to eliminate referral lag, and for nursing and allied health staff to create a habitual practice of entering symptom assessment scores at each assessment. So we generated simple interventions to address our key drivers, and we quickly implemented them. For example, to address key driver 4, the purple one, we ensured that all members within the project team and the palliative care team had access to what we call PAL Centre software, and received internal training on how to enter breathing-related distress scores onto the software platform in real time. An external education session was also pre-arranged by a representative from Peacock within the time frame of the project to facilitate uptake within the facility. So to address key drivers 1 and 2 and 4, we delivered an in-service in May where staff had an opportunity to talk about the project, talk about their experiences of assessment, and they were oriented to the project. The session promoted their buy-in as nursing case managers, and as nurses particularly is primarily responsible for ensuring that timely 7-day follow-up of breathing-related distress for their patients who were screening moderate on admission. Staff were encouraged to enter scores for breathing-related distress even when the score was 0. So common practice prior to this was that clinicians would score patients, they would document on EMR patients who had a score of 5 or more, so severe, heading towards severe breathlessness, and this left a gap where people who scored 4, who might still have had moderate symptoms, may have been missed or not prioritised. Individual patient data was accessed electronically via the Power Centre software that you saw on the previous screen. I collated this into an Excel spreadsheet and then produced a line graph. And this was collated fortnightly and presented monthly to the palliative care team. And that way they could monitor their own progress as a team and see where areas of improvement were needed. Excuse me. So on the graph, the x-axis is the date at 4 weekly intervals, and the y-axis was the percentage of people with at least moderate breathing-related distress on admission who were reassessed within 7 days. The dark blue line was our pre-intervention mean, and that represented data entered between August 2020 and January 2021. And on average, 34% of people had that repeated breathlessness assessment within 7 days. So at the bottom of the graph, you can see it dips and then it increases quite sharply. And what that is likely reflecting is the Christmas period. And then it also then reflects the Power Centre software being introduced into Calvary. So that increase to 50% there in March is kind of where we were sitting before our intervention started. So going a bit further, we then held a repeat in-service for CPCT staff in late June, and that included an updated line graph of the proportion of community patients with timely reassessment of their breathing-related distress. New staff were educated on how to assess breathing-related distress scores. Our doctor commenced a weekly review of moderate to severe scores and ensured that a timely plan was put in place. She also provided ad hoc advice and troubleshooting where there was inconsistencies in scores among the multidisciplinary team. A flowchart was also developed by our palliative care doctor, and that was used to educate and affirm palliative care staff to affirm that optimal assessment and management practices were occurring for patients with breathing-related distress. So this addressed key driver 1 to create consistency of practice in scoring and action to scores. And the flowchart here was used as an educational tool for clinicians and nursing case managers to gather a full patient history, undertake clinical assessment, and also to consider infective causes such as a PE, heart failure, or arrhythmias, and then move on to management based on a thorough assessment. So as a result of these interventions and increased engagement with community palliative care staff, we found that the proportion of breathing-related distress scores re-entered within 7 days increased from 34% to 92% by the end of our project, which was a mean increase of 36% in 5 months and a total increase of 58%. Additionally, at baseline, the mean number of days to a reassessment of breathing-related distress was 8 days, and during the intervention period, the mean number of days decreased from 5.5 at initial assessment to 4.1 at second assessment. and that reached statistical significance at the p less than 0.001 level. The proportion of patients with mild breathing-related distress, so a symptom assessment score for breathing that was less than 3, less than or equal to 3 at the second assessment, was approximately 27%. So as a result of this QI project, a new process map was introduced to screen and manage patients with breathing-related distress, and this was integrated into standard practice. So really, at the start, it was very much clinicians talking to each other, and it wasn't as consistent and streamlined as it is now. So now what happens is in the multidisciplinary, once we see a patient is flagged with a score of 4 or more for breathing-related distress, we look at our breathing flow chart, but also in the morning meeting, we look at patients who are classified as deteriorating using the Peacock system. So patients who do score for moderate to severe breathlessness are automatically flagged as a new phase 3. And conventionally that meant that people were stable, but they were deteriorating within the trajectory of their underlying condition. But now what it means in the community setting is it also means that this person needs to be assessed and potentially have a change in their management. The person then continues to be discussed in the weekly multidisciplinary team meeting until they're no longer a phase 3, and that indicates that no further change in their plan is needed. In terms of sustainability, the project identified patients with moderate to severe breathing-related distress as well as other symptoms. So the new process for flagging deteriorating patients also was then used across other subscale scores on the Peacock assessment. So, for example, bowel problems and pain and nausea. So in other gains from the project, we also now are continuing to review moderately distressed patients and fill staff knowledge gaps in the accurate assessment of symptom assessment scale scores, because it is a score of distress from breathlessness or distress from other symptoms, not actually the severity. And the Peacock system does allow for contemporaneous data entry, and it's really just about encouraging uptake and promoting that within the service. The key learning points from the project is that we identified breathless patients in need of follow-up that we may have missed before, identified staff support needs for breathlessness scoring and management, and we embedded processes for addressing moderate to severe breathing-related distress. In terms of our next steps, there's a couple of things we're thinking of doing. We're looking at the breathing, thinking, functioning assessment. Now, clinicians know that this is ideal to integrate in a breathlessness assessment, but it's, again, not routinely done because of competing priorities and other things. So we want to try and promote that, and plus or minus psychological health support. When we came into this project, the underlying idea was to look at do we need a clinic in our service, because we have respiratory chronic care, but we don't have palliative care driven breathlessness specific services that include a wide variety of patients. So, for example, if they've got a cancer diagnosis, if they've got COPD, if they've got other disease processes, but they are also suffering from breathlessness. So I think our data does give us some justification for that, because at the end of the project, we only had 34% that moved into the mild range. Some of that we won't be able to change given the context of the patient's functional decline, but we feel that if we have an integrated clinic, then we might be able to shift some of those scores and better manage patient-driven symptoms. So to conclude, the proportion of community patients with a reassessment of breathing-related distress increased, and we know that a similar QI project could be possible in other community palliative care teams who use a Peacock symptom assessment scale score. And even if they're using a different symptom, so for example, the ESAS or another scale for breathlessness, the model of this particular QI project could be used and translated to different assessments too. So we found that Stanford Collaborative to be quite helpful. Thank you.